I'm Dr. Fakir Bari, and this is Skin and Soft Tissue Infections in Adults. Let's take a look at the significance of skin and soft tissue infections. In this retrospective cohort study of US administrative claim data, we can see that the incidence of skin and soft tissue infection is about 50 per 1,000 person years. And that is significantly higher than UTIs and pneumonia. And this high incidence leads to a huge economic impact. When we look at a period from the year 2000 to the year 2012, we can see that there was a threefold increase in direct healthcare costs driven by ambulatory care expenditure. And the total population-based antimicrobial prescription rates for SSTIs increased fourfold from the year 2000 to 2012. Here are some reliable resources for this topic. There is the 2012 IDSA guidelines for treatment of diabetic foot infections. There is the 2014 IDSA guidelines for management of skin and soft tissue infections. And in this topic, we will also cover beta-lactam allergies. So there is drug allergy, a 2022 practice parameter update, which is a helpful clinical tool. The first learning objective is identify risk factors for allergic cross-reactivity among penicillins, cephalosporins, carbapenems, and monobactams. When we look at adverse drug reactions in general, not just allergies, but all adverse drug reactions, they account for more than 3% of hospital admissions. Now, drug hypersensitivity reactions in particular compromise up to 20% of all adverse drug reactions, and they are reported in about 8% of general population. And that is all drugs, not just antibiotics or not just beta-lactam, but hypersensitivity reaction to all drugs. Now, the problem is up to 80% of allergies lack descriptions of the reaction. A modern way to look at adverse drug reactions is to think of them as on-target adverse drug reactions and off-target adverse drug reactions. On-target adverse drug reactions are reactions that are essentially based on the mechanism of the action of the drug. So these are things that we actually anticipate. An obvious example is antibiotics, right? So antibiotics are intended to kill microorganisms, but we don't necessarily want them to kill all microorganisms. Specifically, we don't want them to touch the microbiome. Pretty much most antibiotics are associated with C. diff infections, and that is an on-target adverse drug reactions. When it comes to off-target adverse drug reaction, it is useful to think of them non-immunologically mediated and immunologically mediated. Essentially, we need to know if the immune system is involved or immune system is not involved. Now, when the immune system is not involved, we can think of it whether the actual immune cells are involved or not, because some drugs can interact with the receptors on some of the cells, even though the immune system is not activated. An example is when fluoroquinolones interact with the cell receptors on the mast cells, resulting in urticaria. And this is not activating the immune system, but the end result is the mast cells causing urticaria. And that's something that we can see in fluoroquinolones. A non-immune cell receptor mediated example would be aminoglycosides causing nephrotoxicity, in particular acute tubular necrosis. Now, when the immune system is involved, it's good to think of it whether antibodies are mediating it or the T cells are mediating. And to go into more details on this, in general, we like to think of hypersensitivity reactions in 4 types. So type 1, which is the immediate hypersensitivity reaction, and by immediate we mean within an hour, you will have these reactions. It's mediated by IgE, so immunoglobulin E specifically, and this can manifest in serious things, so anaphylaxis, angioedema, flushing, pruritus, urticaria, and hives. Now, type 2 through type 4, these are the delayed hypersensitivity reaction. So by delayed, they're not going to occur within an hour. It will take some time, sometimes even days or weeks. And type 2 is the IgG-mediated cell destruction. And things like hemolytic anemia, neutropenia, petechia, and thrombocytopenia can manifest as a result of this. Type 3 is IgG-mediated immune complex deposition and complement activation. And things like drug fever, serum sickness, and small vessel vasculitis can manifest as a result of this. And last but not least, type 4 hypersensitivity reaction is T-cell mediated. And T-cell mediated reactions can be extremely severe. And because of that, we have actually broken type 4 into subtypes. So subtype 4A, B, C, and D. Type 4A specifically involves macrophages. And this is things like allergic contact dermatitis. And then for type 4B, which involves eosinophils, it can be things like DRESS, so that is drug reaction with eosinophilia and systemic symptoms. Type 4C is T-cell cytotoxicity, so these are extremely severe, so Stevens-Johnson syndrome, as well as toxic epidermal necrolysis. And there is type 4D, which involves neutrophils, and this could be acute generalized exanthematous pustulosis. So when we think of antibody-mediated hypersensitivity reaction, that includes type 1, type 2, and type 3. So these are all antibody mediated, different antibodies. So for example, type 1 is IgE. And when we think of T-cell mediated hypersensitivity reaction, this is specifically type 4. Now let's focus on beta-lactam allergy specifically. Now, most patients labeled with a beta-lactam allergy are actually not allergic. And here are some reasons that they may have been falsely labeled as beta-lactam allergy. So one is that the original reaction might not have been an allergy. So there could be intolerance, for example, nausea or diarrhea. Or maybe the infection had caused a reaction. So for children, they could have had a viral exanthem. Or a drug infection interaction. So if there is a skin reaction due to drug infection interaction, may have been interpreted as a drug allergy. Now, even if the original reaction were immunologic, it might not recur with re-challenge. And more importantly, IgE-mediated reactions to beta-lactams can wane over time. So about 80% of patients who are positive for a penicillin skin test, and 60% of those with a cephalosporin skin test positive are no longer sensitive over a period of 10 and 5 years respectively. Now, there could be serious unintended consequences of mislabeled allergies. So one is that mislabeling patients with a penicillin allergy can lead to the utilization of second-line antibiotics instead of preferred first-line antibiotics, which are costlier, broader spectrum, and in many instances associated with multiple adverse events. The other thing is that patients are expected to encounter more adverse effects and less optimal outcomes when using second-line antibiotics instead of first-line. And this in turn affects healthcare organizations as the length of stay increases, in addition to the cost of care of these patients. Now let's focus on penicillin allergy specifically, and by that I mean the class of penicillins, not just penicillin itself. Approximately about 10% of the US population reports a penicillin allergy, and about 5% of these patients who claim penicillin allergy will actually have a reaction to penicillin. And approximately 95% of patients with a reported penicillin allergy will have a negative penicillin skin test. So if you do the math, about 1% or less of US population actually have a true penicillin allergy. And even if the reaction was a true reaction, keep in mind that IgE antibodies wane over time, so that's important to keep in mind. When we look at the structure of penicillins, of course, there is the beta-lactam ring. For penicillin, there's also a second ring fused to the beta-lactam ring. But more importantly, there is a side chain. So there is a R1 side chain, and that, depending on which penicillin, the R1 side chain will be different. And this will be, when metabolized, essentially you're going to have all these byproducts that are labeled as major determinant or minor determinant. And it is thought that the similarity between the R side chain as well as the degradation of the ring and the stability of the intermediate products determine the degree of cross-reactivity between beta-lactams. And since the overall structure of penicillins is identical and major and minor determinants from the rings play a potentially significant role, it is generally advised to avoid all penicillins in a severely penicillin allergic patient. And keep in mind that this is for severe penicillin allergy, not something as simple as a rash. Now, when it comes to cross-reactivity, we can think of similar side chains. So penicillin, for example, itself has a side chain that's similar to cefoxitin. So let's say if someone had, a non-severe reaction to penicillin, like a rash, they're more likely to also have a similar reaction to cefoxitin. For amoxicillin and ampicillin, their side chain is similar to cephalexin. So if someone had a non-severe reaction to one of these, they're more likely to have similar reaction to cephalexin. Now, when we look at the big picture, if someone has penicillin allergy, the cross-reactivity between penicillins and cephalosporins is actually less than 2%. When it comes to penicillins and carbapenems, is less than 1%. And to date, actually, the rate of cross-reactivity between aztreonam and penicillins is essentially not reported. Now, if someone has cephalosporin allergy, the cross-reactivity between cephalosporins and carbapenems is less than 1%. Now, we have to keep in mind that in general, there is limited data with cross-reactivity when it comes to carbapenems and monobactams, because majority of penicillins, majority of beta-lactams that we use clinically are penicillins or cephalosporins. So we have much more data for cephalosporins and penicillins, less so for carbapenems and monobactams, which the only one in the US is aztreonam. Now, what to do when someone has penicillin allergy? Well, the first thing is that you want to evaluate and investigate to see if it's a true allergy or not. Because if it's not a true allergy, if it's something like intolerance, such as nausea or vomiting, it's safe to use beta-lactams. It's not allergy. Now, when it is a delayed reaction, you want to be very careful because it could potentially be T-cell mediated, and that's very severe. So if it's non-severe, something like itching, even if it's delayed, it is in general safe to administer cephalosporins, carbapenems, and aztreonam, and you don't really have to worry about the side chain. But if it is a severe infection, such as Stevens-Johnson syndrome, and these are T-cell mediated, you really want to avoid cephalosporins and carbapenems, regardless of what the side chain looks like. And it is safe to use aztreonam. So aztreonam will be your only beta-lactam that you can use. Of course, it's safe to use non-beta-lactams. Now, when it comes to immediate reactions, these are within an hour, that could be potentially IgE mediated. For non-severe, it is safe to administer aztreonam or carbapenems. If you are to use a cephalosporin because there's potential for cross-reactivity, you really want to rely on the side chain. So you want to use one that doesn't have a similar side chain. If it is a severe reaction like anaphylaxis or angioedema, you really want to avoid cephalosporins and carbapenems that have similar side chain, because it could potentially lead to anaphylaxis. It is safe to use aztreonam, and if you are to use the side chain to decide if it's a cephalosporin that's safe, it has to be in a monitored setting, because there's the risk of anaphylaxis. So if if you're sending the patient home, it's best not to rely on the side chain and avoid it. But if it's in a monitored setting, it's you can use the side chain. Now, when it comes to cephalosporin allergy, about 1 to 3% of the population report cephalosporin allergy, so even more rare to have cephalosporin allergy, so less than 1% have true IgE reaction. Now, with cephalosporin, there are actually two side chains. So there is the R1 side chain. They actually have a R2 side chain. And the second ring is slightly different than the penicillin. The beta-lactam ring is, of course, identical. Now, something that stands out is that cefazolin actually has a unique side chain. So it has very low cross-reactivity with penicillins. No other beta-lactam has the same cephalosporin side chain. So that's good. So when it comes to deciding similar side chains, we really rely on the R1. Although the R2 side chain may have a role in immunogenicity, it is to a lesser extent. So we'll focus on similarities of the R1 side chain. So I have listed some of, this is not an extensive list, so some of the more commonly used cephalosporins, especially the ones in bold. So as I mentioned, cefazolin does not have similar side chain with anything else. Cephalexin, of course, with ampicillin and amoxicillin, as well as penicillin. Cefoxitin with penicillin, cefpodoxime with cefepime and ceftriaxone. So ceftriaxone, cefepime, and cefpodoxime pretty much share the side chain. So those are best to avoid when one of them is causing a severe reaction. Ceftolozane has similar side chain with cefpodoxime, ceftriaxone, cefotaxime, and cefepime as well. And lastly, with carbapenem allergy, again, even more rare and really limited data with carbapenem allergy. It's not studied as well. The risk of cross-reactivity between penicillins and carbapenems is less than 1%. Now, because carbapenems are unique in that when we need to use carbapenems, we're dealing with some severe infections that we really need carbapenems. And so, it will be tough if you really need carbapenem, and the reason for not being able to use it is a drug allergy rather than resistance. So based on limited data available, an alternative carbapenem agent may be cautiously used in patients with reported carbapenem allergy if no other option for treatments are available. What that means is if someone has imipenem allergy and you really need a carbapenem, you can cautiously use meropenem under monitoring.